Hello everyone, Dr. David Warmflash with another flash moment in medical science. Today's topic is ectopic pregnancy. Now, what that means is when the products of conception implant anywhere other than the endometrium, which is that epithelial lining of the uterus. That's where pregnancy has to take place. And if it doesn't take place there, it's not going to work. It will just not be viable, and it's not safe for the woman either, or the mother. Now, what causes this? Well, first of all, we have to say there are different types of ectopic pregnancy based on which wrong place it occurs. 95% of those take place in a fallopian tube. So that's called a tubal pregnancy. Other ones could take place, other types of ectopic pregnancy can occur really anywhere else. Can be in the cervix, could be on the outside of the uterus, could be on an intestine, could be on the inner wall of the peritoneum. It could even be in the scar of a cesarean section from a previous pregnancy. But when it's in the tube, which is 95% of the time, the reason has to do with the tube being stenotic, meaning narrow. Remember, we talk about stenosis in terms of stenotic blood vessels or stenotic heart valve, like mitral stenosis. The mitral valve is too narrow. Or aortic stenosis, the aortic valve is too narrow. Well, the same thing with a fallopian tube. You can have a stenotic fallopian tube. The reason you get that is from inflammation. Inflammation is a good answer all the time with, what is the pathological process leading to something. An inflammatory process results often from an infection, and that's what happens in the case of having a stenotic fallopian tube. It's from pelvic inflammatory disease, which often is a result of chlamydia or gonorrhea, but it's possible to get that from other sexually transmitted infections. So that actually brings us to risk factors. What makes it likely for this to happen in the first place? And we already gave you a clue as to what's a reason why someone would have it. Somebody who has a history of PID, of pelvic inflammatory disease, she is at risk of ectopic pregnancy. What's an even bigger risk factor for ectopic pregnancy? How about you already had an ectopic pregnancy? Because if you already had an ectopic pregnancy, and if it was a tubal ectopic pregnancy, well, that means that your tube was already, at least one of your two fallopian tubes is too narrow to allow the products of conception to come through soon enough to implant into the endometrium of the uterus after fertilization has occurred. What's another risk factor? Infertility. If you've been trying to get pregnant and yet you haven't gotten pregnant, one of the reasons for that inability to become pregnant could be that you have a stenotic fallopian tube, or both fallopian tubes are stenotic, and that means that the ovum is never getting through in the first place, or the sperm is not meeting up with the ovum in the fallopian tube, or the ovum just barely made it through the tube and got into the uterus late, and by the time it gets fertilized by sperm that's in there, it's already on its way out of there. And just the timing isn't right. The timing, really, there's a narrow window of just a few days to get pregnant, a couple of days before and after ovulation is the time when the woman needs to be exposed to sperm, either through sexual intercourse or through some kind of an artificial means like artificial insemination, or they might be doing something more sophisticated, such as IVF, in vitro fertilization and embryo transfer, which we will do in a totally different video. We'll cover various technologies like that. Now, let's just go through briefly what happens in fertilization and in the days after that. What happens is that there's a whole lot of sperm that gets into the cervix, but only a very, very tiny proportion of that, about 1 in 10,000 sperm cells, actually makes it all the way up to the fallopian tube, where by that time there should be an ovum that has been released. And that's where the fertilization usually takes place and has to take place if the woman is going to become pregnant. But if the tube is stenotic, then this whole process can get slowed down. Now, if the tube is okay, what's normally happening is that fertilization will take place. It means there should be, a couple of hundred sperm cells or so will be working on that ovum because it's surrounded by a protective barrier called the zona pellucida. And you need a couple of hundred sperm or so to release enzymes that weaken the zona pellucida to allow the genetic material from one lucky sperm to get inside that one lucky ovum. And each of these two gametes, the sperm, male gamete, and the ovum, the female gamete, has just a haploid genome, meaning only one set of chromosomes, which will include either an X chromosome each, or they'll include a Y. And if both have an X, you end up with a female 2X. If one has an X and one has a Y, you end up with a boy, XY. This is under the normal circumstances. There's a lot of abnormal things that can happen too, but we'll get to those also in other video episodes. Now, once you have fertilization, you have a zygote, and that begins the cell division process. It divides into a two-cell stage, a 4-cell stage, and so on as it continues moving through the fallopian tube. At some point, you don't call it a zygote anymore. When it's, say, from 16 cells up to about 60 cells, you call it a morula. It's just a ball of cells. And when there's a cavity inside and cells start to move toward different sides of the fertilized entity, now it's not called a morula anymore, it's called a blastocyst. And the blastocyst is actually what does the implanting into the endometrium if everything is going right. And that usually happens about 5 to 6 days after fertilization. So basically, to go through the process, sperm gets in there, there's already been ovulation. If the timing is right, fertilization happens inside the tube. The development starts, 2-cell stage, 4-cell stage, more and more cells, morula, blastocyst. But by the time there's a blastocyst, you better be out of the tube by that time and ready to implant in the endometrium. But if you're slowed down because there's a history of PID and there's been this inflammatory process, the tube is narrow, you can't get through that tube, and as a result, well, you can get stuck in there. And the risk factors for that, pelvic inflammatory disease, previous tubal pregnancy, or previous ectopic pregnancy of any kind, DES, which is diethylsylvestral, but that's not so common anymore. It was given from the 1940s up to 1971, and it's a risk factor for women whose own mothers received DES when the mothers were pregnant with the woman who is now pregnant. And that means it's really only a risk factor now in the 2020s for a mother who's in her 50s, which is not so common, but you will still see it on the exams. Another risk factor is endometriosis, which is when you have endometrial tissue all over, not just inside the part of the uterus where it's supposed to be, but all over the place. So yeah, bunch of different risk factors. Know those risk factors. Now, if the fertilized blastocyst, then, well, if it's blastocyst, it's already fertilized, so that's a little redundant. If the fertilized entity in the blastocyst stage, when it's implanted in the tube, where we could really start calling it an embryo from that point. You can even call it an embryo a little bit earlier. Even the 2-cell, 4-cell stage, fertility people, they already call that an embryo. And if that gets stuck in there, then it's going to be an ectopic pregnancy. It's going to be a tubal pregnancy. How would you know this is happening? Well, the first is that you got to know the woman's pregnant. That'll be a positive pregnancy test. And the second is abdominal pain. Those two things together. There's a kind of a pearl that goes if there's a woman in her reproductive years, meaning after she started to get her period and before menopause, and she's missed her period, she is pregnant until proven otherwise. And if there's a woman in her reproductive years who's pregnant and meaning has missed her period and is experiencing abdominal pain, she has an ectopic pregnancy until proven otherwise. So that's the beginning. It's pain and a positive pregnancy test. Now the pregnancy test initially, if the woman does it herself or if done initially in the doctor's office, it's a qualitative test done on the urine for beta HCG. But it can be done quantitatively, checking the level of beta HCG in the blood, and by seeing if there's a high enough level of HCG for how far advanced the pregnancy should be, you can get an idea of whether it's a healthy pregnancy. With ectopic, it could often be that the level of beta HCG is too low because it's not doing so well. That's often a clue that the pregnancy is not going to be viable, whether it's an ectopic pregnancy or not, that there's going to be a spontaneous abortion. But it may not abort spontaneously, and if the woman starts to get abdominal pain, it's that it's stuck in the fallopian tube, and first you got to establish that there's a pregnancy there. In addition to doing the beta HCG and doing the quantitative beta HCG, you do ultrasound and look for a gestational sac, and then see where is that gestational sac. Is it in the right place? Now, if it's not in the right place, that's a problem, and it has to be removed. It's not going to be viable. You cannot transform that into a viable pregnancy. You can't translocate, say, the developing embryo of a tubal pregnancy into either the proper location or to an artificial uterus. We do not yet have a working artificial uterus. There's some really fascinating research in that direction. They're doing some amazing things, especially at the University of Pennsylvania. They've demonstrated on lamb fetuses. But it's not ready for prime time yet, and maybe another generation or so, and we still don't know really how we would do the transfer, because there's a lot of things that happening with the blood supply and whatnot. It just cannot be done, which means if there's a tubal pregnancy, sadly, it's not going to be a viable pregnancy no matter what. So the pregnancy has to be ended. The first choice in this case is to use a medication abortion. Now, before we get to that, we should also say a little bit more about the differential diagnosis when there is abdominal pain. You want to rule out other things like appendicitis, like familial Mediterranean fever, like diverticulitis, even upper abdominal, things that usually cause upper abdominal pain, like cholecystitis. all the different sources of abdominal pain, you want to rule those out. Having another bout of pelvic inflammatory disease also could be abdominal pain. You want to rule out all of this. But once you know that it's a tubal pregnancy, it has to be terminated. So typically what's done is you try first, at least unless it's really big by that point, medication abortion, which can be done. Often the abortifacient agent that's used is methotrexate, but there are other ones. And then if that is not adequate, at that point you got to move toward the procedural approach, surgical procedure. Often this can be done, in almost all cases, with a laparoscopic procedure. Laparoscopic surgery means instead of doing a laparotomy, where you open up the peritoneum and be able to get your hands in there to manipulate things, you're just making 3 or 4 tiny little holes to allow entry of trocars, which are tubes through which instruments can be passed. One little incision is made to get the first trocar in, to get a tube in there where the abdomen can be insufflated with CO2, carbon dioxide, to expand it to allow some working space in there. And then another tube goes in with a fiber optic tube to put a lot of light in there, along with a camera for the surgeons to be able to see what's going on in there. And then other tubes can allow passage of instruments. And these are specially elongated instruments that people have to practice to learn how to use, and they can do whatever they need to do. In some cases, they can do what's called salpingostomy, where you can just kind of make a hole to relieve pressure and kind of get the products of conception out and make sure they're out and preserve the fallopian tube. But it often, in many cases, that's not enough, and they have to do a salpingectomy, where the tube itself has to be resected along with whatever's in it. And then you have to make sure that everything that's supposed to get out of there is taken out of there to avoid very dangerous situations like peritonitis and sepsis and all kinds of terrible complications. And that pretty much takes us to the close of just the basics of ectopic pregnancy. And we'll see you next time when we do a flash moment in medical science. Have a great rest of your day.